of the Oral and Maxillofacial Surgeons of India, Tamil Nadu and Puducherry chapter, and the Craniofacial Academy of Stryker, to this fantastic session on principles of neck node dissection, spoken to us from the most distinguished panelists from their vast knowledge and surgical experience. As all our webinars, this is also a unique webinar by itself. We have with us to moderate the Vice President-elect of the International Association of Oral and Maxillofacial Surgeons. We have with us the President of the International Association of Oral Oncology and the Director of the Kochi Cancer Center. And we have with us more friends from from Adelaide, Australia. In a new friend, we have Professor Suren Krishnan. Along with that, we have young blood in Dr. Madan and Dr. Abhinan. So we are looking forward to a fantastic session with the distinguished panelists. I also acknowledge the presence of Dr. Sam Brook, who's been with us in all these webinars throughout to this session. And I would like to place on record also that this webinar has hit a record of more than 600 registrations already. I will be corrected by Dr. Suresh and Dr. Jimson if the numbers have increased further. So looking forward to a great session along with you, learning with you. Here I am. Have a great time. Thank you. Dr. Jimson, over to you.
Thank you, ma'am, for your welcome address. Now it's over to Dr. Suresh to introduce our moderator.
Thank you, Jimson. Yeah, very good afternoon to everyone assembled here. Today, I'm sure we are going to have a very great session, an academic feast on neck dissections, because we are all very familiar with the controversies in neck dissections, when to do, when not to do, if we are doing, till which level we have to, and whether we do a selective neck dissection or MRND or RND. There's so many controversies. So after the end of this session, I'm sure everybody will carry a clear idea about neck dissections. The moderator and the panelists are going to be seniors and well-experienced surgeons in this particular topic. So it's really going to be light-throwing and interesting for all of us. I shall take the pleasure of introducing today's moderator, Professor Dr. Sanjeev Neuer. He has completed his BDS and MDS from Trivandrum Medical College, Kerala. He was trained as a registrar at the North Manchester, UK from 1994 to 97. In the same tenure, he has completed FFD RCS also. He is currently the Professor and HOD of Oral and Maxillofacial Surgery, Bangalore Institute of Dental Sciences. Also, he is the lead consultant for the Craniomaxillofacial Surgery at BM Jain's Hospital, Bangalore. He has served as an executive committee member of International Association of Oral and Maxillofacial Surgeons and was the vice chairman of 18 ICOMs. Currently, he is the vice president-elect for the International Association of Oral and Maxillofacial Surgeons. He has been doing oral oncology work for the past 3 decades and is an expert in this field. He also possesses a great knowledge and interest in the field of maxillofacial vascular lesions. He has done many researches and publications on these topics. So we welcome you, Professor Dr. Sanjeev Neuer, sir. We are waiting to hear you. And I request you to take over the podium to introduce our panelists for the day and to proceed with the session. Thank you.
Thank you, Suresh. It's a great pleasure. It's indeed a great pleasure to be here with all of you. I must thank the AOMSI Tamil Nadu and Puducherry branch, President Dr. Reena, Dr. Suresh, Dr. Jimson for having given me this opportunity to be with all of you to moderate this session, especially with such an elite group of surgeons from around the world, and the Craniofacial Academy of Stryker for the extreme enthusiasm in being the backbone of all these webinars that are being presented by this society. Thank you very much. We have with us today a very good panel. I think Dr. Reena has mentioned, has given a fair introduction about them, but it would be my pleasure to introduce the esteemed panelists. We have Moni Abraham Kuriakos, a good friend. He is currently the director of the Cochin Cancer Research Center, Kerala, and I think the first maxillofacial surgeon to hold this prestigious post. It is an autonomous government institution, and we are really proud of that. We also have him as the editor-in-chief of the Journal of Oral Oncology, and he's also currently the president of the International Association of Oral Oncologists. Welcome, Moni, and I'm sure we would really be enriched by what you have to tell us and discuss during this session. We also have Professor Suren Krishnan, a guest from Australia, University of Adelaide and Royal Adelaide Hospital. He is the chairman of the Department of Otolaryngology and Head and Neck Surgery at the Adelaide Royal Infirmary. He has done his fellowship from the Radcliffe Institute that's in Oxford, UK. Welcome, Professor Krishnan. We look forward to your participation in this panel. Professor Matan Mohan is a dean at the Karpaka Vinayaka Institute of Dental Sciences. He is also the consultant in Oral Cancer Foundation and the Apollo Hospitals in Chennai, a very enthusiastic young head and neck surgeon, and we are very eager to see his contribution for this panel. And we have a very young and dynamic head and neck surgeon, Professor Abhinand Poturi, who graduated incidentally who did his post-graduation from my alma mater, that is Trivandrum. I'm glad to see him on this panel. He's currently the professor at the SVS Institute of Medical and Dental Sciences. He also is a consultant in Premier Hospital and Fort Hospital. Welcome, Dr. Abhinand. So we shall start with an introduction, a brief introduction regarding the topic. I hope my screen is shared.
Yes, sir. Yes, sir.
Yes, Dr. Sanjeev.
So, so without much delay, now why NecK dissection? Because as we all know, it's one of the main prognostic tumor factors in the treatment of oral cancer. We had a very, very interesting webinar last Sunday. I think Dr. Shubhra was actually hosting it, and she did a fantastic job about the diagnosis of oral cancer and the management of oral cancer. And there is no management of oral cancer without actually addressing the issues about the cervical lymph nodes. As we know, the tumor dissemination to all the regional lymph nodes in the neck, or the lymph nodes in the neck, occur in a very predictable and sequential manner. And this is set to halve the 5-year survival rate. So shows how important it is for us to address the neck at the time we address the primary in the treatment and management of oral cancer. Coming from Memorial Sloan Kettering was the description regarding the different levels at which the lymph nodes could be identified. It was initially identified as 5 levels, and then they added on a 6th level to it. It was level 1, which was the submental and the submandibular group of lymph nodes. Then you had the level 2, 3, and 4, which is divided at the level of the hyoid bone and at the level of the cricoid cartilage into the 3 levels, that is superior, the level 2, which was further subdivided into level 2A and 2B by the accessory nerve. Then you had level 3, which was the mid-level jugular lymph nodes, and you had the inferior level jugular lymph nodes, which was at level 4. And the nodes in the posterior triangle, which are referred to as level 5. Now, as you can see, the most controversial part of the treatment of oral cancer was managing the neck. And managing the neck, especially in situations where you did not have a clinical or radiographic positive neck, you would depend upon a situation where it was referred to as a occult neck metastasis. And how do you identify the occult neck metastasis? So statistics have shown that in most cases, you have over 20% incidence of occult neck metastasis, except of course in a situation where the primary is in the buccal mucosa or involving the lower gingiva. Now, neck dissections broadly were classified into therapeutic, opportune, and elective by Kowalski. Therapeutic essentially being those neck nodes which were positive and were being treated as part of the loco-regional control of the disease. Opportune when it was treated along with access as part of the primary surgery or as part of the reconstruction, and elective when you had a negative neck clinically or radiologically and you had treated it for therapeutic purposes in the future. So I go on to the speakers of today. We have Abhinand who will start off with investigating the neck. I request Abhinand to start with sharing his screen. He will give us a brief 5-minute presentation on the investigation of the neck as a part of the management of the oral squamous cell carcinoma. Abhinand, over to you.
Yes, sir. Thank you, sir. I'll share my screen now. I think this PPT has to be closer so that I can share it.
Yeah, sure.
So is it visible, sir, the screen?
Yeah, it is.
Yeah. So good afternoon, everyone. Before I begin, I must thank Association of Oral and Maxillofacial Surgeons of India, Tamil Nadu and Puducherry branch for giving me this opportunity to be on this platform with these esteemed panel members. And the topic allotted to me today is investigating the neck in oral cancer. I'll be talking very briefly on this because anyway, we have the discussion to come up in the panel. So we will be just briefly covering on what are the various investigative modalities when we have to identify the neck mets. So why to investigate the neck in oral cancer? That's the first point. In prima facie, we know that presence of a neck node, palpable node or a met in the neck is an unwelcome sign. And we know very well that it straight away decreases the survival rate by 50%. In presence of a contralateral node, it decreases it by another 50%, and extra nodal spread, extra capsular spread further hampers the prognosis of the disease. So, and also it is important to know the precise staging of the disease, and in order to make us decision on the adjuvant treatment to be given after the surgical treatment. So what are the ways we can investigate the neck? One is the time-tested method, the clinical examination or the physical examination, then the various imaging modalities, whereas like Cct, MRA, ultrasound, guided FNAB or PET-CT. Then we have the best way is pathological, there where you can either do a sentinel node biopsy or you can do the elective neck dissection or the neck dissection, therapeutic neck dissection, whatever, depending on the situation, to establish the status of the neck nodes. So if we go into the literature, the clinical examination part, this is a meta-analysis which was published in the year 1997, which straight away says that physical examination has got sensitivity compared to that of the CT scan. When it was compared to the CT scan, much less, with a statistically significantly low. That is, accuracy of physical examination is just about 77% compared to that of the 83% with the CT scan. And this goes to say that the clinical examination is not reliable in all the situations, especially when the node size is smaller and when we have occult metastasis, when sub-centimeter level nodes are there, it is very difficult to appreciate the nodes merely by physical examination. This is where our imaging modalities will help us in establishing the presence of neck mets. So as I said, physical examination identifies only 75% of the pathological cervical adenopathy, whereas detection increases almost 90% with the additional aids like we are going to discuss now. So when you see the options, various options in imaging modalities, this is again a meta-analysis which was published in the year 2007 from Georgia, where they have compared various modalities, the CT scan, ultrasound, MRI, USG guided FNA-B or FNA-C, and then ultra-small particle iron oxide MRI. And when they compared all of this, they have found that USG FNA-C is found to have highest amount of detection in cervical node metastasis with the detection rate of almost 260. So this is what gives an undue advantage or overt advantage of USG guided FNAC over other modalities. But there is a problem here. This study, this meta-analysis has included N0 and N plus NecK also. So when the confusion comes when we are with the occult nodes. The problem is when we have to identify the occult metastasis to the cervical lymph nodes. So this is a prospective study which was conducted from TMH, the Tata Memorial. And this clearly says that when we consider only N0 NecK and eliminate the N plus from the diagnostic modality, then the sensitivity of USG guided FNAC comes down to almost 14.3% compared to the ultrasound or sentinel lymph node biopsy, which is obviously has got very high detection rate. So this is one of the disadvantages of USG guided FNAC when we talk about in N0 NecK, especially when the lymph nodes are of smaller in size, where it might be difficult to identify. So this is the comparative study where the TMH, where they have done most of the their sample size was an early T1, T2, N0 NecKs. You see how the sensitivity has come down straight away to 14%. Specificity might be 100%, but if we are not able to identify the nodes, there is no point in having higher specificity in these lymph nodes. Compared to other studies where the sensitivity is slightly higher because they have included all clinical T stages. So what are we going to look for when we actually do this ultrasound? One, no doubt, the size of the node, but more than the size of the node, just merely the size of the node, we need to look at the width. Width of about greater than 7 to 10 millimeter is considered to be significant as far as the nodal size is concerned. And also the outline and the shape of the node. The classical shape of the node is usually elongated and a kidney bean shape. But whenever there is alteration in the width because of the tumor infiltrates present inside the node size, node shape tends to change to spherical. As you can see here in this picture, this is what is a significant finding on ultrasound. Apart from that, presence of irregular borders, rim enhancement, and also, as you can see in this picture, these are the irregular borders you can make out. And then this is where it shows presence of extranodal, extracapsular spread of the tumor. So these are the very, very important findings which you need to look for when we do the ultrasound examination of the NecK. Coming to Cect and Mra evaluation of the NecK. The Cect MRA in Indian setup especially, whatever the primary modality of screening for the primary tumor, that is whether you go for Cect or MRA, the same would be preferred for the NecK also. Usually the MRA is preferred in soft tissue tumors, something like a tongue where coronal views will give you the depth of invasion, clear picture. The same modality can be used for the NecK also. But when we suspect some cortical erosion or cortical involvement, then Cect would be a preferable mode. But again, if there is some bone marrow invasion, MRA would be an ideal. This I'm talking in perspective of primary tumor. So same thing we can use for the NecK node investigation also. So again, here the important thing is the nodal size and shape. The short axial diameter is one of the important method of finding out the presence of METs in the node. That is greater than 10 millimeter of SAD is an indication of high sensitivity towards presence of NecK node METs. A maximal longitudinal depth to transaxial width ratio of again less than 2. That means the node becoming spherical in shape is again a strong indication for the presence of the NecK node, positive NecK node. Not only that, but also another important thing we have to notice is presence of central necrosis or non-homogeneity, that is heterogeneicity, which is again indication of invasion of the tumor into the node. That is on CT, if you see, this will manifest as a central area of low attenuation, whereas on MRA, this manifests as a central area of hyperintensity and central non-enhancement. So extracapsular spread, another very, very important thing, because presence of more than 1.7 mm of extracapsular spread will severely derail the prognosis of the patient. So on CT, if you see, this one again show as a rim enhancement and thickened nodal rim, and typically with the infiltration of the adjacent fat planes or loss of adjacent fat planes. So this is how it is. So best radiological predictors for pathologically proven extracapsular spread is presence of central necrosis or cystic transformation of the lymph node, presence of irregular borders and gross invasion of the adjacent structures, change to spherical shape, and change in SAD with the loss of the increase in the diameter or the with the short axial diameter or the width. Coming to the role of PET CT scan is one of the most investigated methodology now, and a lot of papers coming up on this. And one of this study which was published from the Korean group says that the use of 18 FDG PET CT reduces the probability of occult node metastasis to 12% as compared to that of the 21% in case of CT MR imaging. But there is a problem here again, because the FDG, which is it fails to detect very small size metastatic lymph nodes. It is limited when the size of the lymph node is slightly larger, but when it goes to sub-centimeter lymph node, there is a spatial resolution problem, and then it fails to detect. Not only that, with the PET CT, there is another problem. It will also, the SUV value is also, it can also catch up in some inflammatory lesions, some muscle hypertrophies, where it can confuse, though SUV values might be slightly different between these two, but still it becomes a confounding factor there in identifying the NecK PETs. And more than 40% of metastatic lymph nodes, especially when we are talking about occult nodes, they are less than 7 mm and even up to 2 to 4 mm, which invariably the PET CT is not suitable when the nodes are so small in size. So when we talk about occult lymph nodes, lymph node metastasis, which are very small in size, sub-centimeter size, then PET CT usually doesn't have a major role, but it will be useful, PET CT, in identifying and staging the disease, and also in identifying a distant metastasis in stage 3, stage 4 kind of tumors. So coming to sentinel lymph node biopsy, this is a pathological way of diagnosis, and it will be useful not only as a diagnostic tool, but also now we're talking as a therapeutic alternative to elective NecK dissection. This is a paper meta-analysis which they have compared 66 studies when they have used sentinel node biopsy as a diagnostic tool, and they have identified that pool identification rate is almost 96.3% with sensitivity of 87% and negative predictive value of 94%. This indicates that it has got very high sensitivity, though it has got certain disadvantages, which I'll be talking about in the later slides. So this meta-analysis suggests that sentinel node biopsy has a high diagnostic accuracy when we are talking about clinical N0, T1, T2 kind of oral squamous cell carcinoma, and it can be an ideal alternative to elective NecK dissection. But this is a SENT3 trial which was published in 3-year result published in 2015, where they have compared 415 patients with radiologically staged T1, T2, N0 NecK. And then they have found that sentinel node they were able to identify in almost 99.5% of the cases. That's very high predictability. But positive sentinel nodes were found in 23%, and wherever they have found the positive nodes, they had taken back the patient to the theater 3 weeks later, and they had to do the elective NecK dissection. Whereas the disease-specific survival, when they could find that the sentinel node biopsy was negative, it was almost 94%. That indicates that high predictability of sentinel node biopsy. So the sensitivity is almost 86% with negative predictive value of 95%. That's the advantage. But there are some drawbacks with this. One thing is time consuming, because it has got a learning curve also. And another, the problem with that, because we have to go back, and whenever we find a SNP positive node, then we have to, because it takes about 8 to 10 days for the report to come in, because they do serial sectioning and immunohistochemistry, unlike the regular biopsy specimens. So once you get the report, you need to go back and then do the NecK dissection again. So this will usually need second surgery, and always it will interfere with the decision making of microvascular reconstruction. Suppose you have done the reconstruction already, then you have always the problem of going back and doing the NecK dissection when biopsy report comes back as positive. And there is again 10 to 15% of false negative report also, which we need to be wary of. So from this, what my take home points are: physical examination, yes, reliable, but it has got low sensitivity, especially when the node size is smaller or in N0 NecK. Cct MRA, the most reliable of all the imaging modalities which are available now. Depending on the primary, whatever you do, you can extend that to the NecK also. PET CT, not suitable in smaller sub-centimeter nodes, but indicated in stage 3 and stage 4. Sentinel node biopsy, it is evolving to be one of the best diagnostic and therapeutic alternative in early T1 and T2 N0 stage. And elective neck dissection is one of the best tools to stage the neck and currently the best option in staging the N0 neck. Thank you, one and all. Sir?
Thank you, Abhinand, for the lucid presentation on regarding the investigations in the neck. I haven't seen many questions. There's only one question asked, which I think will be answered as we go along with the panel discussion. So I request Dr. Matan to share his screen and start with his presentation. And while he's doing that, Abhinath, is it a routine practice to do a PET scan for all your patients?
No, sir, not routine, sir. Only when, as it said, when we suspect that the disease is in stage 3, stage 4, it will be helpful for us to identify the presence of neck nodes. So staging will be more precise, sir. And also if there is any suspicion of distant mets, which are anyway rare, but for these, only in those circumstances, not for every case.
I think we'll come back to the specifics of the specific indications of neck node.
Yes, sir.
Madan, unmute and speak. Yeah.
Jim, can you hear me, Jim?
Yeah, we can hear you.
Can I start?
Yes, Madan.
Okay. Good afternoon, one and all. And my topic of presentation for today is selecting type of neck dissection in oral cancer. And as a small introduction, as the previous speakers told, nodal metastasis is the most important prognostic factor with respect to any cancer, Similarly, in oral cancer, a spread to the regional lymph nodes reduces the survival by 50%, even in the absence of distant metastasis. This nodal metastasis should be treated adequately in all the patients with oral cancer. Even in N0 neck, the neck should be addressed with either radiotherapy or surgery to get a better result. And if there is a positive lymph node after a neck dissection, then patient should be properly treated with adjuvant treatment. Recent clinical TNM staging, in the recent clinical TNM staging, it shows the important thing which was added was N3B. And the N3B node states that metastasis in any node or nodes and clinically overt extranodal extension if it is positive N3B. N3B has extranodal extension has its own importance and significance with respect to adjuvant treatment. This should be seen both with imaging in clinical staging and with the postoperative histopathological examination. In the postoperative histopathological examination, if the metastasis is in a single ipsilateral or contralateral lymph node, 3 centimeter or less in great dimension, with the extranodal extension, if it is positive, it should be addressed with chemotherapy along with radiation. Similarly, metastasis in a single ipsilateral node more than 3 centimeter in greater dimension and external extension positive or metastasis in multiple ipsilateral, contralateral or bilateral lymph nodes with external nodal extension positive. Again, it should be addressed properly with adjuvant treatments. Coming to the different types of neck dissection, radical neck dissection, we all know that radical neck dissection was the previously followed neck dissection across the world. This all started in 1980s by Jardinsky, and then in 1906, this was refined by John Kreil, and in 1952, this was properly organized into a properly organized neck dissection by Hayes Martin. In radical neck dissection, all the non-lymphatic structures, that includes sternocleidomastoid muscle, spinal accessory nerve, and internal jugular vein will be removed along with the fibrofatty tissue of the neck from level 1 to 5. Then modified radical neck dissection came into existence. In modified radical neck dissection, again divided into 1, 2, and 3. In 1, spinal accessory nerve will be preserved. All the other structures will be removed along with the fibrofatty tissue up to level 5. And then in level 2, spinal accessory nerve and internal jugular vein will be preserved. And in level 3, all the 3 non-lymphatic structures, including sternocleidomastoid muscle, will be removed. But this is not common with oral cavity cancers. These days, with oral cavity cancer, we are not doing modified radical neck dissection, because now with the literature we know that there is no there won't be any involvement in level 5. Extended radical neck dissection. Some cases where there is a huge node infiltrating any one of the structures, non-lymphatic structures, that includes sternocleidomastoid or internal jugular, or both internal jugular, sternocleidomastoid, and spinal accessory nerve, sometimes involving the skin, sometimes nodes in the pretracheal, parapharyngeal, or in the midline nodes. Then we extend the neck dissection accordingly, which is called extended radical neck dissection. These days, we very commonly do selective neck dissection. Selective neck dissection is the common procedure for oral cavity cancers these days. And in oral cavity, we have 7 subsites, and among the 7 subsites, except for tongue, all the other subsites, we clear the levels 1, 2, 3, and preserving spinal accessory nerve, sternocleidomastoid muscle, internal jugular nerve, internal jugular vein, and other structures. For tongue alone, we clear up to level 4, because for tongue, the level, the skip metastasis happens with, even in the level 4. In some cases of tongue where you won't find any nodes in level 1, 2, or 3, and sometimes you can find nodes in level 4. That's the reason you have to do selective neck dissection up to level 4 in tongue. Coming to occult metastasis. Occult metastasis is nothing but in cases where there is a proven oral cancer, but clinically there won't be any node. But we have a confusion whether to address the neck or not. With this study, with the Weiss et al. Study, that occult metastasis is greater than 20%, then we have to do. Which 20% of the cases, that usually tongue with N0 neck, or floor with N0 neck, or retromolar trigon with N0 neck usually has occult metastasis. These are the conditions that we have to mandatorily address the neck with radiation or surgery. But generally, for all N0 neck, we have to address the neck. These are 2 studies which shows the patterns of cervical node metastasis from squamous cell carcinoma of the upper aortic tract. Predominance of certain levels was seen for each primary site. Level 1, 2, and 3 were at highest risk for metastasis from oral cavity cancer, and level 2, 3, and 4 were at highest risk for metastasis from carcinomas of oropharynx. This is a study done by Jatin Shah and group, which shows that for oral cavity cancer, we have to do selective neck dissection up to level 1, 2, and 3. And tongue, we have to do up to level 4. And the frequency and therapeutic implications of skip metastasis in the neck from squamous cell carcinoma of the oral tongue. This was done by Robert Byers, which shows all patients with squamous cell carcinoma of the oral tongue should have level 4 nodes removed if an elective neck dissection is part of their initial therapy. And this study, very recently done from Tata, this is a prospective study with more than 600 patients done on N0 neck with the early stage cancer, which shows that among patients with early stage cancer, elective neck dissection resulted in higher rates of survival. Higher rates of survival for N0 neck if the neck is treated, and disease-free survival than did their neck dissection. Another study, nationwide randomized trial, which is evaluating the neck dissection for early stage oral cancer, which is a SEND study, which shows that SEND and the cumulative evidence shows that with a generalized setting of oral cancer who have an upfront elective neck dissection have a lower risk of death recurrence for all stage tumors. For all stage tumors, even this concludes, states that for all stage tumors that neck dissection should be done. With this, I conclude my talk, and I thank the Tamil Nadu Pondicherry chapter, AOMSA, for giving me a chance to talk in this forum. Thanks.
Thank you, Dr. Madan. And I would request Moni to start sharing his screen. Meanwhile, just to recap on what Madan was trying to explain. There is the definitive role of doing a selective neck dissection from levels 1 to 3, which is also called as the supraomohyoid neck dissection in all primary sites of the oral cavity, except the tongue, where you address level 4 as well. And Madan, a question to you. Madan, can you hear me? There is one question that has been asked. Madan?
Sir, yeah. I can hear you, sir.
Yeah. So what is the role of modified radical neck dissection in addressing the neck, in an N-positive neck?
In N-positive neck, if in case where there is a N3 node, and when there is no involvement of internal jugular vein or any other non-lymphatic structures, then we can do a MRND3 in those cases.
Okay, thank you, Madan. So we'll go on to Moni.
Thank you, Sanjeev. Can you see my slides?
Yeah, we can.
Thank you, Dr. Reena, Dr. Sanjeev, for the kind invitation. So I'm going to cover the topic of controversies in the management of N0 neck. So I'm going to take 5 minutes of your time and discuss this topic. So before I discuss the topic, what's the issue we're going to cover in this N0 neck? What are the issues which has come up in the literature in the recent past? So if you look at that, we heard it before, N status is a very important predictor of outcome. Every speaker before has mentioned. Another problem, if there is a N0, if there is a clinically and radiologically N0 neck, still there is about 34% chance of occult metastasis. Then we heard this before, that there is a predictable pattern of metastasis. We're going to ask this question again, is that true or not? Second, the fourth issue we heard from Abhinav about the importance of imaging. We have to add some kind of imaging to properly evaluate the neck, because that will increase the nodal staging or change the nodal staging by about 20 to 30%. And 25% of the occult metastasis is too small to detect by imaging. So even if the imaging say that there is no metastasis, still there is about 25% chance that there
I think there is a problem with the audio. We've lost Moni.
Yes, sir. Not able to hear him. His screen is, yeah.
Moni, you're
Sir, you are
muted.
muted.
And your screen has to be shared as well.
Okay, 1 minute, 1 minute.
Yeah, yeah.
Can you hear me? Can you hear
Yes,
me?
sir, we can hear you. Yes, sir, we can hear you, sir.
All right, okay. Yeah. I'm sorry about the issues. Let me get into that. So we heard about that when to intervene. We'll come to that. And the extent of neck dissection, Dr. Mathan explained that. We'll touch upon that. So
The
this
screen
is
share,
an important paper.
Screen share, Moni.
Can you see my screen?
Yeah.
Okay.
Yeah.
So this is a very important paper, came up 2 years ago from India, from Dicruz group, from Tata. So they looked at, took almost more or close to 600 patients with N0 neck. And one group, they did elective neck dissection. The other group, they did therapeutic neck dissection. We heard the definition. If the patient developed a recurrence later, they underwent a neck dissection. And they showed very clearly, Mathan also quoted this paper and showed that if you do elective neck dissection, we can improve the cure rate by almost like a 15 to 16, 20% improved cure rate. No intervention in oral cavity had this kind of impact. So with this paper, the conclusion was we have to subject every patient with N0 neck elective neck dissection. Let's think through that during the next few minutes. So what are the issues I want to cover? We need to, when we should call a neck really N0. So what's the definition of N0? When we need to call it as N0. Second is that issue about therapeutic versus elective neck dissection. Let's have a deep dive into that. And lastly, I want to touch upon the sentinel node biopsy. What's the role of that? Now, the first, we heard from Dr. Abhinand that we have to do some kind of imaging. And I mentioned before also, about 20 to 30% of the neck can be altered, either N positive or N negative by some kind of imaging technique. And choosing one imaging technique, the other one hardly make a huge difference. We need to use some kind of imaging technique. Most of the time, as Dr. Abhinand mentioned, we have to use the same imaging which is used for the primary, needs to be used for the neck. Second is about, let's look at this important paper which came up. And after this publication, a lot of people have got into this doing neck dissection for almost every patient with N0 neck. Let's look at that paper in detail. If you look at the paper in detail, it has shown that there's a high incidence of nodal relapse in therapeutic neck dissection. Therapeutic means patient being weighted. These are N0 patients, so they observed, and then when the patient developed neck node, they did the therapeutic neck dissection was carried out. The tune of 45%. As we heard earlier, the occult metastatic rate is normally only about 30%, 25 to 30%. This is very higher compared to the general population. So we need to question that study population. Then the other issue came up is that 21 of the therapeutic neck dissection was picked up by the N3 stage, and 20 of them were inoperable. Mind you, these patients were followed up by serial ultrasound scan, and still when they picked it up at the N3 stage. Again, we need to look at the validity, the accuracy of this data. Then third issue is that high number of patients with elective neck dissection received radiotherapy. So if you're comparing two groups of the intervention, both should have the equal amount of extent of intervention. And elective neck dissection received 48% of the elective neck dissection received radiotherapy, while only about 34% received radiation, the therapeutic neck dissection. And 23% of the therapeutic neck dissection had extra capsular extension. We'll come to that during the discussion time. And most of these patients should have received chemoradiotherapy, but did not receive chemoradiotherapy. Another important feature is that when they did a post-hoc analysis, they found that patients with less than 3 millimeter depth of invasion, very superficial lesions, did not have any benefit by elective neck dissection. So that point we need to keep in our mind when we're making the decision about subjecting patients for selective neck dissection or elective neck dissection. The last point is about is there a role for sentinel node biopsy? And Dr. Abhinand pointed out that we know what that technique involves. Let's look at the largest study published so far, the SENSE study. We heard from Dr. Abhinand as well as Mathan about the SENSE study. Let's look at the data fairly detailed. And this study had about 480 patients. Out of that, 415 were included in the study. If you look at the DCRU study, had almost 600 patients, 585. And out of that, 46 had a midline disease, and the other remaining had lateralized disease. And if you look at the pattern of nodal pickup, about 60% of them had bilateral nodal disease. So central lesion, we have to be mindful of bilateral nodal pickup. Second issue is that even in a lateralized disease, about 9 of them had contralateral disease, and about 40 of them had bilateral disease. And out of 9 patients, 7 of them had positive nodes. So these could have been missed by the only ipsilateral disease. This we could have prevented if you have subjected the patient for a sentinel node biopsy. And if you look at the remaining data, out of this, the patients, 94 had positive sentinel node positive disease, but 23%. That's fairly accurate to the real world data. About 25% will have occult metastasis. So almost all of them, they picked it up. And 17% of them had extra capsular extension. So this came to a sensitivity of 86%. What is very important to appreciate is that 95% had a negative predictive value. That means if sentinel node is negative, we can be assured that the patient is really in negative. Okay. In those patients with almost 77% of the patient had a negative sentinel node, and then they followed up the patient, and then they found that remaining when the N-positive disease did the completion neck dissection, 50% of the patient had additional nodes, and number of patients underwent radiotherapy. If you look at the number here, it's only 12%. In the DCRU study, it was much higher. Almost 40% had adjuvant radiotherapy. And when they in sentinel node negative patients, they followed up, and 4.6% had failure in the neck, but they could salvage. A majority of the patients were salvaged, and chemoradiotherapy was given in 12 of the 15 patients. So if you summarize the result, sentinel node biopsy is oncologically safe with a disease-free survival of 92% compared to elective neck dissection So definitely we can say it's an oncologically safe procedure. And whether this can be used as a test to identify metastasis. Sentinel node identified in almost 99% of the patients and failed to detect only in about 14% of the patients. And out of this, the 14%, that the 15 number of patients, 8 of them they could salvage. And what is most important is that it identified a number of unexpected contralateral or bilateral metastasis. To summarize, ladies and gentlemen, we have to do some kind of imaging technique to be sure that the neck is truly N0. Therapeutic neck dissection versus elective neck dissection. Definitely we have to, there's a value for elective neck dissection, but in selected patients, there is still role for observation. Hopefully that will come up in the discussion. And is there a role for sentinel node biopsy? Definitely there's a role for sentinel node biopsy. Thank you very much for your attention.
Thank you, Muni. Very interesting. And Muni, question while we wait for Professor Krishnan to share his screen. Are there any shortcomings in the sentinel node biopsy investigation? I mean, is there any deficiencies in that you can point out when we do a sentinel node biopsy? False positives or false negatives?
Yeah, two major problems. First is that we have to subject the patient a second operation. That's one problem. Second is that if the sentinel node is in the level 1 area, submental area, with a primary in the floor of mouth or lateral border tongue, sometime we can miss the sentinel node. So level 1, we have to be careful. And there are ways to get around with these two problems. The first problem, we can do a SPECT CT scan. So instead of doing a regular SPECT scan, if you do a SPECT CT scan, then we can identify even the level 1 node. Now, coming to the avoiding second operation, there are newer techniques coming up for a real-time detection of the sentinel node, intraoperative detection of the sentinel node. But that we have to wait for trials to prove it.
Thank you. And we move over to Professor Krishnan, who will talk to us about the complications in neck dissection. Professor Krishnan, over to you.
Thank you, Sanjeev. Am I audible? Can you hear me?
Yes, yes, Professor Krishnan.
Oh, good.
Yes, you are.
Very much.
Yeah.
Thank you, Sanjeev, for inviting me to participate in this discussion on neck dissections. Greetings from, Greetings from Adelaide. So Adelaide is in South Australia. We are a small state, a population of approximately 2 million. We have wonderful vineyards. We have the usual furry animals and lovely beaches. And we've got a new cricket oval. We'd love to see Indians visit us for the test matches that are coming up. I'm from the Royal Adelaide Hospital, which is a very well-established hospital, over 150 years old, which is here in South Australia. And the pictures you can see are the pictures of the old hospital. And this is a new hospital that we've built, about a $2 billion project and a $1 billion research facility that our government's invested in. I take time to acknowledge my mentors and colleagues. And amongst them, you'll see Dr. P.V. Rajagopalan, who was a graduate of Stanley Medical College in Madras and was one of our leaders. I also take time to acknowledge members of our head and neck multidisciplinary clinic that makes our head and neck service so good. And amongst those names, you'll see Dr. Sam Brook, who's been a great contributor to head and neck oncology in our state and country. So my topic is neck dissections, and really the issue is avoiding complications. And as usual, this begins from before you start the surgery, and you can basically divide your approach to complications as preoperative, intraoperative, and postoperative. And as we've heard, case selection is important, and that you have to choose what operation you're doing, and you have to decide why you are doing the operation. You have to understand your patient's medical comorbidities and assess them and address them before surgery. And I think really the interesting part for surgeons is the intraoperative issues and how you can avoid traumatizing the vital structures of the head and neck. And part of this is understanding that neck dissection is a very prescribed and systematic surgical operation. It involves clearing the lymphatic tissue, which is in an envelope or fascial tissue, lying from the mandible to the clavicle, from the midline to the anterior border of the trapezius, clearing all the tissue deep to platysma and superficial to the prevertebral fascia, and sparing the neurovascular bundle that traverses through the neck, and to defend structures that are important for function, such as the marginal mandibular division of the facial nerve and the accessory nerve. And postoperatively, to recognize that these patients are fragile patients, and if you recognize complications early and address them early, you can prevent serious complications. So from a case selection point of view, as I said, we've heard about radical neck dissection, modified neck dissection, and selective neck dissection. And this depends on the amount of disease, the volume of disease in the neck. And as is fairly inevitable, the greater the operation you do, the greater the risk you have to the anatomical structures in the neck. From a medical comorbidity basis, we have a problem with diabetes, as I'm sure is in India. And there are cardiovascular, and in our population, which is aging, a neurovascular issue with dementia and frailty amongst our people. So we have a population in their 70s, 80s, and 90s that have this disease that still want active treatment. It's also important to consider previous treatment, particularly radiotherapy, but surgery as well can affect skin viability and makes you think about the incisions you plan. And generally, we would avoid trifurcate incisions. So a trifurcation is an area of opportunity for skin necrosis. And if you have to make a trifurcation, avoid the trifurcation over the carotid artery. And if you have issues of skin viability, then plan how you're going to cover this, whether this is going to be with the workhorse pectoralis major myocutaneous flap or a free flap. So intraoperatively, the idea is to avoid injuring the neurovascular bundle. And as I said, the three things that are prime in our minds are the marginal mandibular division of the facial nerve, the spinal accessory nerve, and of course, the thoracic duct. As far as the neurovascular bundle is concerned, then if you prescribe, have a prescribed approach, and our approach is an approach to remove the structures from posteriorly and work upwards and forwards. And if you use this approach, generally speaking, you won't come across the vascular structures until you have a broad aspect to these structures. It's very important that you handle these tissues carefully because of the risk of bleeding, but also because if you perforate the vein, for example, the internal jugular vein, and you're not aware of it, then it can suction up air and you can get issues such as air embolism. And so you must be mindful at all times of being very careful with the vessel. And if in fact you have this problem, then be mindful to respond to changes in the patient's constitution reported by your anesthetist. With the carotid artery, be careful again that you might create a carotid sinus injury, and that can cause reflex bradycardia and even cardiac arrest. But also in our population, as it is an increasing incidence of atherosclerosis, and rough handling of the carotid artery can cause thromboembolism and cerebrovascular accidents as a result. So be careful with the internal carotid artery and internal jugular vein. Identify them in a broad front, dissect and remove tumor in a very careful fashion. So be respectful then that within the contents of the carotid sheet will be the vagus nerve. Be very mindful of the hypoglossal nerve. Again, systematic approach. We use the digastric as a landmark, and if you use the digastric as a landmark, then you know that you can be pretty careful of dissecting deep to the digastric, where you will find the hypoglossal nerve. And of course, it would be a significant tragedy if you injure the hypoglossal nerve in a patient who has, for example, a total laryngectomy because that would really cripple a patient, and it's a complication you don't want to give them. The phrenic nerve and the brachial plexus and the sympathetic chains are just generally beneath the prevertebral fascia and quite away from the standard neck dissection. So it's only at risk when you have extended neck dissections in tumors in level 4 and level 5 in the region of the supraclavicular fossa. And understanding the anatomy of these structures is important. On the right of the slide, you'll see a picture of how to ligate the internal jugular vein. And again, this is a very important issue when you're transecting the internal jugular vein as part of a radical neck dissection, that you must make sure that both the superior stump and the inferior stump are secured. And this can be done by putting in a transfixion suture through the vein before you divide it. The marginal mandibular division of the facial nerve is not a vital nerve in terms of absolute function. However, it can interrupt oral incompetence and can cause patients to drool, so it should be treated with respect. And this is a photograph from an Indian paper from Batra, published in the Indian Journal of Plastic Surgery. And what I wish to use this picture to illustrate is this very constant relationship demonstrated in a number of papers, that the marginal mandibular division of the facial nerve lies between the platysma and the facial vein and the facial artery. So that if you perform the so-called defensive incision practiced by Hayes-Martin, or the Hayes-Martin maneuver as it's sometimes called, they can identify the submandibular gland fascia roughly at the level of the hyoid. And then if you raise your skin flap, your superior skin flap deep to this fascia, you will identify the facial vein. And if you work under the facial vein and keep the fascia as part of your flap, almost always will you be able to defend the marginal mandibular division and the fact that it has a number of branches. So it's important to realize if you do identify the marginal mandibular division of the facial nerve, understand that it has several branches, and that these branches usually are at the level of the mandible, but some of them can dip down 1 and sometimes 2 centimeters below the mandible. And so acting in a defensive fashion can prevent injury to the marginal mandibular branch of the facial nerve. The other nerve, and the one that troubles us more, is the accessory nerve. And the injury to the accessory nerve is reported as between 2% and 40%, depending on what papers you read. In our own patient-reported quality of life measures, looking at 1,000 patients, the incidence of injury to the facial nerve was about 3.5%. But I think that the way to approach the accessory nerve is to have in your mind a surface anatomic landmark of where the nerve is. And what I teach is to tell people that if you drew a line with the patient in the position for surgery, with the neck extended and rotated away from the site of surgery, then if you drew a line from the tragus to the acromioclavicular joint in a roughly curvilinear line, you'll find the cause of the facial nerve. The more reliable but still variable landmarks are how far the accessory nerve is from the clavicle, which in some studies is said to be about 5 centimeters, but 7 centimeters from the clavicle. But a more reliable marker is the relationship of the spinal accessory nerve to the great auricular nerve at the posterior border of the sternomastoid. And at Erb's point, which I think is actually where the greater auricular nerve comes from the posterior border of the sternomastoid, about 1 centimeter above it, you will find the accessory nerve. If you're doing a modified neck dissection or a selective neck dissection and you're approaching the nerve from medially, so you're making an incision along the sternomastoid and then rotating or retracting the sternomastoid away and dissecting, roughly you find the accessory nerve again along this curvilinear line and at the anatomical plane of the tendon of the sternomastoid muscle. So if you're careful at that stage, almost always you'll identify this nerve. This nerve has a very steady relationship to the internal jugular vein. In about 90% of occasions, it will head towards the internal jugular vein and lie anterior to it. In about 10% or so, it might lie posterior to the vein. In about 1% of cases, it can actually pierce through the internal jugular vein to gain the skull base. Injury to the accessory nerve is a significant problem in the sense that it means that the patient will not be able to support their forequarter, and that causes both pain and dysfunction. A number of these patients will be able to retain function, will have some amount of limited function due to limited abduction, due to some adhesive synovitis. So we encourage early physiotherapy for these patients. The next structure that we all worry about is the thoracic duct. And as you know, this is a duct that takes most from the body. It's predominantly on the left-hand side, and it enters the neck, root of the neck, deep to the carotid artery and the jugular vein. And then in most cases, in about 90% of cases, inserts at the junction of the subclavian vein and the internal jugular vein. The anxiety here is particularly in the left neck, but about 25% of cases of thoracic duct injury can occur on the right side. And the way to avoid this is to try and make sure that you are in the correct plane, superficial to the prevertebral fascia. And if you can identify the leak, if you do transect the thoracic duct, then the idea is to control the leak at the time of surgery. And this often, you can see, Kyle, it's a very filmy, somewhat creamy colored fluid on occasions. It can be exacerbated. You can get your anesthetist to give the patient a Valsalva maneuver, and this can cause an increase in the leak of Kyle, and there you can identify where the leak is. If you're lucky and you can identify the exact leak from the thoracic duct, you can ligate it either with a clip or with a non-absorbable suture such as 4-0 silk. But sometimes you might need to oversew what remaining fascia remains in this supraclavicular fossa, or you might need to rotate a flap, either the anterior border of the sternomastoid, or if the sternomastoid has been removed, you may even need to turn in a pectoralis major flap to control the bleeding, but control the Kyle leak. But the best time to control a thoracic duct leak is intraoperatively, and at times I've even used the microscope to help me identify a leaking thoracic duct and oversew it. If you are unfortunate and you have the problem of post-surgery, then the management is to keep the patient at rest, because movement and exercise and activity increases the amount of chyle that's secreted, and then to put them on low-chain fatty acid diets or medium-chain fatty acid diets, and this will tend to slow down the secretion. And generally speaking, these are low-flow lesions, but if you're unfortunate and if you have a high-flow lesion secreting more than 500 a day, then you might need to reopen and investigate and close this leak, because this does interrupt the healing, promotes infection, and also can cause significant protein losses and electrolyte malfunctions in patients. So finally, post-operatively, it's very important to keep a close eye on these patients. As I said, watch their electrolytes, watch their hemoglobin, because these help with recovery and healing. Look out for infection, keep a close eye on the skin flap. Some of our patients, as I say, are old and frail, and we put them in high dependency and intensive care units for follow-up. Keep a close eye on their drains, looking for both seromas, blood, hematomas, leaks. And if you're doing a procedure in conjunction with an intraoral procedure, they may well have a salivary leak. Be fastidious in ensuring they're well nourished, and then, of course, the most important thing, of course, is to do a NecK dissection that will prevent any remnant disease or recurrent disease. So make sure that you follow them up and plan appropriate adjuvant treatment. Sanjeev, that's the end of my talk, and I hope that addresses the issues of complications of neck dissection. And my last slide are the references from which I base my talk. Thank you very much.
Thank you, Suren. That was a very concise explanation of the complications that one can encounter when dealing with neck dissections. And just a moment. I have not been able to access the question and answer. So Suresh or who's got access to the question and answers, if there are any interesting questions pertaining to the completed lectures, we would be able to address that at this moment.
Suresh?
Yes, sir. We all can access to it, sir. The questions. There are about 10 or 12 questions in the question and answer section. The first one is on moderately differentiated squamous cell carcinoma of the buccal mucosa, which is clinically N0.
Yeah, I think that will be answered along with our case discussions, because we have got some interesting cases which have those typical cases. Yeah, that can be addressed along with that. Yeah, I finally accessed the panel of question and answers. Yes, so I'll just go through it very quickly. And there is one question asking, is there any advantage in doing USG Doppler neck scan preoperatively as an additional imaging modality? This is to Abhinand. Abhinand, if you're unmuted.
Yes, yes. Sir, if you don't mind, can you just repeat the question, sir?
Advantage in doing ultrasound guided Doppler neck scan preoperatively as an additional imaging modality. Has it got a role in the imaging of the neck?
Yeah, definitely, sir. It will help in giving, as long as it is used as an additional information modality, it can be used. It only adds to the cost factor in Indian scenario. But it will definitely give us the information about the local vascularity, because it's a Doppler ultrasound he was talking about. So that will give us an additional information of probable the hotspots in the node and also the extra lymph node spread of the tumor.
I guess it would also give, yeah, sorry.
Yes, sorry.
Yeah, it will also probably give you additional information regarding if you are going in for a microvascular reconstruction, whether the vessels are intact, especially if you are encountered with a patient who has already been treated in the neck or has undergone.
In case of repeat case,
has undergone radiotherapy in the
Yes.
past, so you can see the kind of vascularity, persisting in the neck. So that is one question. To Suren, how to manage internal and external carotid artery damage if it gets punctured at the time? I think, yeah, Suren, this is for you.
So can you hear me, Sanjeev?
Yeah, I can.
Yeah, good. So, I'll address external carotid first. The external carotid artery, if you suspect you've injured a major branch of the external carotid artery, just be absolutely sure that it is the external carotid artery. So identify at least 2 branches from the vessel. Almost always you can identify the superior thyroid branch, and then look for a second branch, which more medially will be the ascending pharyngeal, or more superiorly will be the facial or lingual branches. And once you've confirmed that, then you can ligate the external carotid artery. That's not a big problem. And what I would recommend, though, is if you can actually find the branch and ligate both ends of the branch, that would be the best way to control the external carotid. The internal carotid, of course, you must ensure that there is patency. And so with this, what I would usually do is get someone to tamponade where the bleeding is with just finger pressure or with a gauze. I then work below where the bleeding is and identify and encircle the common carotid artery. And then I go above where the bleeding is and identify both the internal carotid artery and the external carotid artery, and then put ligatures around those. And then you can get appropriate vascular clamps. So as part of my head and neck set, I always have a vascular tray available. And then you can put a side clamp like a Satinsky clamp and clamp all of these, identify where the hole is, and if possible, oversew it. And we usually use a 5-0-proline suture to oversew it, and then you can release all the clamps. Try and keep occlusion of blood supply to the cerebral cortex to less than 20 minutes. So the less time you can spend, the better. And I also make sure that there's two suckers available so that you can have the best vision you can to help you control the bleeding. Is that are you happy with that, Sanjeev?
Yeah, that's fine. Thanks, Suren. Thank you. So we move on to, are there any more questions, Suresh, or shall we move on to the panel? And maybe we can take up some of the questions after the panel, since we have to discuss through about 7 cases in the panel. So shall I go ahead with the panel?
Yes, sir.
Yes, sir. Yes, sir.
Yeah.
Please.
So this here is a very interesting scenario. You have simultaneously, we have presented 2 cases. The case on the left, as you are facing it, is a 48-year-old male with no risk habits. You can see that it's a ulceronodular lateral tongue lesion in the middle region of the lateral tongue. Biopsy proven squamous cell carcinoma of the right oral tongue, and N0 NecK. On the right-hand side, you can see is a, my God, it's a 28-year-old actress with no risk habits, with a N0 NecK again, and biopsy proven squamous cell carcinoma. Similar site, but one is a ulceronodular lesion and one is obviously a flat plaque-like lesion on the tongue. So to Abhinand, how would you go about investigating if these patients present to you? I mean, what would be your first line of action?
Yes, since it is anyway established by biopsy that it's a squamous cell carcinoma in both the cases, and since it is a lesion on the tongue, probably the best modality to know the depth of invasion and the extent of the lesion would be the MRI, as far as the imaging modality is concerned. So I would extend the same imaging modality to the neck to check if there are any nodes which are positive in the neck and address accordingly. But as you said, it is N0 NecK already. So if it is N0 NecK, then we will straight away going according to the treatment plans. But this is the imaging modality I would prefer in this case, the MRI.
Mathan, regarding addressing the neck, would you have any difference in philosophy of addressing the neck in the nodular, ulceronodular lesion vis-a-vis the plaque-like lesion on the right-hand side in the actress?
Madan, you're muted. You have to unmute.
Madan, you're muted. You're muted again.
Yeah, now it's fine.
Can you hear me, sir?
Yes.
Yeah.
Yes.
I think the panelists keep themselves unmuted for now because it will be questions from one to the other. So,
okay. With both the lesions, I don't think there is the neck dissection decision is not going to change in both the lesions. In both the lesions, I think we have to go up to level 4 and do a selective neck dissection.
Suren, do you have a difference of opinion with that?
Sorry, Sanjeev, I just missed the question. The question was?
Whether your management of the neck would differ in the lesion from the right
That's the
and the
T1.
left, between the lesion from the right and the left. Yeah, that both are T1, M0 neck lesions.
I know I would have probably the same approach for both.
So, Moni, what?
Yep, go ahead.
Yeah, Moni, do you
Yeah, this is a situation where we have to individualize. If you go by the literature, every N0 need a neck dissection. But if you look at that 48-year-old the person with N0 by imaging, but with the depth of, with just feeling, you know, that's more than 5 millimeter, that just by the look of it. So definitely there is about 30% incidence of occult metastasis. We have to do neck dissection, no question about that. But the other person we are talking about, 28-year-old patient, if you look at the lesion, it's a superficial lesion. That lesion has arose from a surrounding leukoplakia. Okay, this kind of lesion tends to be a superficial lesion, and if you feel that depth is not deeper, this is a case we need to think about or consider sentinel node biopsy. We heard from the Abhinand's talk, and I showed that central data, the negative predictive value is more than 95%. If the sentinel node biopsy is done, and if the node, sentinel node is negative, we can very safely observe that patient. And I note that patient is an actress, so particularly important in this person. So I would go for sentinel node biopsy for the 28-year-old, and the other patient I'll
Yeah, so without asking you who the actress is, of course, I will actually, think that keeping in mind the fact that, you know, as minimal morbidity as possible, the primary lesion will be addressed. Now, would the fact that she's an actress change your modality in terms of the primary treatment as well? Would you opt for radiation vis-a-vis surgery?
No. Primary treatment is same. It's an actor actually. It's a primary treatment is same. No difference. It has to be surgery and appropriate neck dissection, and based on the neck status and primary status, give adjuvant treatment. So the treatment, the approach per se will not change.
Okay. Thank you, Moni. We shall move on to the next case. So again, here is a situation where you have two patients, one a 52-year-old with no risk habits, T2, N0, M0, plaque-like lesion in the left buccal mucosa, biopsy proven squamous cell carcinoma. So it is a T2, N0, M0 lesion. And you have the other lesion on the right, which is a patient with a history of chewing, kind of a erythematous lesion, T1N, sorry, T1, N0, M0 again, squamous cell carcinoma, left buccal mucosa. Now, in both these situations, both are biopsy done. In terms of investigations, would you follow it up with, what kind of investigation would you follow it up with? I would ask Moni.
I would go for CT scan, that puff cheek technique, and then look for any nodes in the neck.
Yeah, Moni, another question I wanted to ask you. Do you in a lesion which frankly looks like a malignancy, would you do a scan first or a biopsy first? I mean, this is for the interest of the general audience, because we have a lot of trainees here who have always raised this question.
Yeah, it doesn't matter. First, we have to prove it's a cancer or not a cancer. If it was a erythroplakia, I don't need an imaging. Okay, so always we will do a biopsy, prove it is a tumor. Now the question is whether the biopsy will increase the uptake in the enhancement within the primary site. Unlikely.
So, Suren, how would you address the NecK in this situation?
Yes, Sanjeev, I think these are always tricky ones. I agree with Moni that we would do a biopsy first to prove that this was cancer, and then we would do a CT scan of the neck. And almost always, even if there is a reactive lymph node, our radiologists would be able to give us advice whether there is disease in the neck. Regardless, our tendency with these is to perform selective neck dissections of 1, 2, and 3. But particularly with these tumors, you have to be very careful that you're not missing out on the facial nodes. So with these, when you're raising the superior flap, you hug the facial artery and the facial vein and identify the facial nodes. And there's usually 1 or 2 lymph nodes because these are the first echelon nodes. In response to Moni's pursuit of the sentinel lymph nodes, we've been very interested in sentinel lymph nodes in Adelaide since about 1999 and have had a variety of techniques. We are currently looking at a nanoparticle iron molecule and using a novel metal detecting device and investigating its utility in identifying sentinel nodes. So this patient would be someone we would ask if he'd be interested in being enrolled in our sentinel node study, but we do not perform sentinel nodes as standard of care in Adelaide at the moment.
Thank you, Suren. Abhinand, any difference in the management?
No, sir, I would stick to that, sir. Definitely, since it's an established squamous cell carcinoma, definitely the elective neck dissection, level 1, 2, 3. Probably we can spare level 4 because the skip metastasis incidence with the buccal mucosa cancers is very rare, almost 0%. So elective neck dissection level 1, 2, 3.
Coming back to Moni, Moni, how was this? This is your case, which I have put forward. So was there any neck dissection done in both the cases or just one of the cases and observation?
Yeah, both the cases we did do neck dissection and both were negative in this situation. But you know, cell node biopsy person which we are discussing here, now usually we recommend cell node biopsy when we do not want to do a neck dissection. Elderly patient with a lot of comorbidity, we want to avoid neck dissection, shorten the procedure. These situations we do sentinel node biopsy, and also for recurrent situations.
Matan, for the sake of the trainees in our audience, in the lesion on the right side, the white plaque-like lesion, would you recommend a particular site for the actual incisional biopsy?
I don't see the clear-cut lesion. The entire lesion looks like a leukoplakic plaque. We would retract properly. I think the lesion is clearly in the vestibule of the vestibular region, and if wherever the lesion is clear, in that area I would take a biopsy rather than taking from this white patch.
So you would choose to do the biopsy from the margin of the lesion?
Margin of the patch, that white patch.
Okay. So any questions, Suresh, in the question answer panel? Any questions? Dr. Suresh? We'll go on to the next case. 78-year-old farmer complains of nodular growth, irregular nodular growth with ulcers in the upper jaw, anterior region, is of 6 months duration. He's been a smoker for the last 6 decades, no other comorbidities. Matan, any investigation? How would you go ahead with the with investigating this patient?
This particular case, I would initially do a biopsy, and once it is confirmed, then I would do a CT scan of that CT scan of both maxilla, CT scan of head and neck region. That includes IV contrast for the neck and CT scan of the maxilla. In the maxilla, to assess whether there is any bony involvement or it is just ulcer which is growing from the gingiva. And in the neck, I do a IV contrast CT scan to look into for nodes. These are the investigations I would do.
Yeah. So as you can see, a CT scan shows there is involvement of the alveolar region, and it's the staging, the clinical and imaging staging would be T4, N0, M0. Biopsy proven squamous cell carcinoma. So regarding the management, Abhinand, how would you manage this patient without nodes in the in either sides of the neck?
So actually, that's what. So the as far as primary is concerned, it will be Brown's type C defect, where while local excision will be done. But regarding the neck, as far as neck is concerned, probably since it's a maxillary tumor and anterior maxilla, the incidence of neck node mets is almost very, very low, sir. So I would be very cautious in deciding whether to address the neck or not. And if at all my investigation imaging modality finds presence of any reactive nodes, that would be the level 1, level 2, level 3 elective neck dissection. Otherwise, probably I would avoid doing the neck dissection also.
Suren, you have an opinion on this? Suren, you're muted. I think you have to unmute you.
Sorry. Yeah, sorry. Yeah, so unfortunately, we would probably address the neck, and we would do bilateral neck dissections in this patient. So this patient, we would have a free flap reconstruction following the defect. So if nothing else, it allows us the opportunity to identify vessels for reanastomosis. I think that the point I made with these anterior maxillofacial lesions, we are very concerned about the possibility of facial lymph nodes. So this is not part of the deep cervical chain, and we would be concerned about that. And in this case, also probably level 1A lymph nodes.
Moni?
Same approach. Composite resection, bilateral neck dissection, reconstruction.
Yeah, so I think it's the panel agrees on the fact that this patient would be addressed with bilateral selective neck dissection. I think the levels would be from level 1 to 3, and obviously follow it up. It was pathologically the staging came back as T4, N2A, M0. And there was extra capsular extension in the left side node. So does that change your philosophy of management post-surgery, Moni?
Yeah, so this is a very bad prognosis. So you have a patient with extra nodal extension. So there are some very good data to suggest that if there's an extra nodal extension, patient should get concurrent chemoradiotherapy in an adjuvant setting. Now, according to the new staging criteria, it will be a PN3B.
So it will be, yeah. So the nodal status would be a 3B, yeah, actually, which is a pathological staging. And we agree that he would require follow-up chemoradiation as part of the treatment. Moving on to the next patient, you have a 53-year-old female with ulcer in the upper jaw, present for the last 2 months with mild pain, habits of betel chewing and smokeless tobacco for more than 40 years. Hypertensive for more than 10 years under medication. And this is the presentation, about a 3 to 4 centimeter lesion. It is ulceroproliferative in the buccogingival sulcus, retromaxillary region. And how would you investigate this patient, Abhinand?
Yes, sir. Again, since it is abutting the maxillary bone and extending downwards, my investigation modality will be contrast and CT scan. which would encompass the primary lesion along with the neck, investigating the neck. So that would give me the fair idea of neck involvement along with the primary extension of the primary lesion.
So the neck, the image on the neck was done. The CT scan shows actually infiltration into the medial pterygoid muscle. And if I come back to Moni about this, Moni, would you suggest the type of maxillectomy that would be done for in this situation, where it is infiltrating into the pterygoid muscle?
Yeah. So this will be staged as T4B situation. So T4B, but in a tuberosity of the maxilla as well as buccal mucosa, T4B doesn't have that bad prognosis as compared to, say, oral tongue T4B. So it's a so we should not we should offer this patient curative intent treatment. So our approach would be a composite resection by a transmandibular approach, not a Weber-Ferguson approach, and then infratemporal fossa clearance with division of the pterygoid from the skull base. The content of the posterior maxilla, along with the content, along with the infratemporal fossa content, needs to be removed.
Yeah, so like Moni suggested, most of these posterior or retromaxillary lesions with infiltration in the pterygoids, essentially you would require a compartment resection involving the skull clearance of the intratemporal fossa as well. And Matan,
yes,
regarding the neck in this post addressing the neck, you have addressed the neck. You have mentioned that this is one of Matan's cases. You have mentioned that there is N2C pathological staging. So I would assume that there was, hello, Matan?
yes, yes,
Matan,
sir, yes.
you have muted yourself. Yeah, Matan, yeah.
Sir, can you hear me, sir?
Yeah, I can. So this was to start off with the N0 neck, and post resection with the neck dissection, you discovered it is an N2C. So how did you follow it up with this patient? Any adjunctive treatment?
Sir, there was a contralateral node, sir. Even before the surgery, that was identified. And then we underwent bilateral neck dissection, and that node was a metastatic node on the contralateral side.
Yeah. So when you identify a contralateral node, how do you confirm the incidence of the contralateral node being positive?
Sir, for this, we did a FNAC of that node and confirmed it is a metastatic node. And then we did the neck dissection on the contralateral side also. And in the postoperative histopathology also, it came out clearly as a metastatic deposit in that node.
So post-operatively, when you did the adjunctive treatment, did you address both sides with radiotherapy as well? Bilateral neck?
Bilateral neck, we addressed with radiation. Radiation, in fact, we discussed with the medical oncologist, and then we have decided to give chemoradiation and proceeded with chemoradiation in this case.
Okay, thank you, Matan.
Can I ask a question to Madan as well as to other panelists, including Moni? What the approach is, whether you did this trans-orally with a facial degloving approach or transfacially with a lateral rhinotomy or a Weber-Ferguson approach?
I think the choice, oh, sorry, okay, Moni, yeah.
No, go ahead, Sanjeev.
No, I think the choice would be a transmandibular approach for a posterior maxillary lesion. I think Moni would agree with it as well. I think.
Yeah.
Especially if you are doing an ITF clearance. Yeah, Moni.
Yeah, for the benefit of the residents in the group. So when we are choosing the approach, Dr. Krishnan mentioned about different approaches. Transoral, transfacial, transmandibular, and everything. So the approach should be there to give maximum exposure to the most difficult area of resection. And if you look at the most difficult area of resection is at the pterygomaxillary fissure and infratemporal fossa. If you approach it by transfacially or transorally, the back end of that resection always in the blind spot. That's where it's going to bleed, you can't see it. So that's where the problem comes. So to approach this, do a simple lip split and raise a cheek flap and raise the cheek flap over the masseter and go underneath the mesenteric fascia so the facial nerves are protected, expose up to the zygomatic, the buttress, then expose the angle region and detach the masseter from that angle region and detach the masseter from the zygomatic buttress and do an angle ostectomy or mandibulotomy at the angle. And then you swing the lateral, the mandible laterally. Okay. So that will give a beautiful exposure of the infratemporal fossa. Prior to do that, you detach the medial pterygoid from the medial surface of the mandible. So here you can see that medial pterygoid at the anterior aspect is involved. So cutting a muscle half or complete make no difference in the outcome, in the functional outcome. So you remove the entire medial pterygoid muscle, not just what you can see in the scan. And then you come and detach the lateral pterygoid from the condyle, come to the skull base, separate the origin of the lateral pterygoid, the upper head, from the sphenoid wing, the pterygoid crest of the sphenoid wing, and then cut the pterygoid plates at the root. And then you can remove the entire content in one block. But people worry about bleeding from the infratemporal fossa. Definitely is a problem. So what you do is to avoid that, Dr. Sanjeev and others who does the vascular malformation knows that we don't go into the lesion, we go around the lesion. Similarly, consider all the muscles are venous plexus. You go around the muscles and then attack or approach the foramen ovale at the end. That's where the maximum bleeding happens. So it's a fairly safe and standard procedure practice throughout our country.
Thank you, Moni. At this stage, we will just stop and take some questions. Dr. Suresh, is Dr. Suresh or Dr. Jimson?
Yeah, Dr. Sanjeev, sir, there are
Rina.
questions.
Yeah, please. Can you ask the,
yeah,
because I can't see the question answer panel for some reason. So,
okay.
Please go ahead.
So there is a question on the maxilla. If there is a T1 or T2 maxilla with an N0, would you do a neck dissection? That's a question, sir.
Selective neck dissection.
Yeah, would you do a
N0,
neck dissection if
neck,
there is a T1 or T2 on the maxilla? Maxillary T1, T2 with an N0 neck. Will you do a neck dissection? Do you need to address the neck? Dr. Sanjeev, sir, you could ask one of the panelists. Yeah.
Matan?
Yes, sir, of course. I do a neck dissection in the maxilla, that is in the alveolus. If not, the lesion is a sinonasal tumor or an exclusive maxilla tumor, which is lying inside the maxilla. Other than those kind of lesions, I don't know how to go about in neck dissection. If the lesion originates from the alveolus or gingiva and invading the palate or the buccal mucosa, whether it is T1 or T2, I would address the neck with the neck dissection, level 1, 2, 3.
Okay, Moni, if there is a small T1 lesion on the gingiva without bony erosion on the maxilla, would you subject the patient to a neck dissection?
Yes, I do. There is a paper from the memorial some years ago, maybe 10 or 12 years ago, showed that very high incidence of nodal metastasis in gingival lesion. We're not talking about, as Dr. Matan mentioned, a maxillary sinus tumor, alveolar carcinoma. There's a high incidence, I don't remember exact number, with occult nodal metastasis. So invariably, we do ipsilateral neck dissection for these patients. I may be wrong. That's what we practice in our group. So,
yeah, I think Dr. Suren also mentioned that in many of these situations, it would be an opportune neck dissection as well, because you would require to do a microvascular anastomosis of your reconstructive component, and which would require exploration of the neck. So you would be opening up the neck to do that. So you might as well sample the nodes that are present in the neck. Reena, any other questions?
Yes, there is a question on the need for adjuvant therapy. How would you decide on adjuvant therapy if there is? Can you hear me? Can you hear me, Dr. Sanjeev?
Yes, ma'am. Yes, ma'am. We can hear you, ma'am. Yes, ma'am.
Okay. So the question is, how do you decide on advising adjuvant therapy if there is a lymphovascular infiltration or extra capsular spread or a perineural infiltration, Dr. Moni, sir?
yeah, I'll take
I think Dr. Sanjeev will. Yes, Dr. Moni, sir.
Okay, there is a very good paper from Australian group. Suren is there. Okay, they looked at when to give adjuvant radiation for early stage tumor. Okay, and so here we need to look it up at the primary tumor factors as well as nodal factors. And if you look at the primary tumor factors, if there are two high-risk features along with a early stage tumor, you need to recommend adjuvant radiation. So what are the high-risk features? Close margin, perineural invasion, lymphovascular invasion, or a pattern of invasion, which is a infiltrative pattern of invasion. If any of the two features along with T1, T2, we have to recommend adjuvant treatment. Now the question is whether to give, if everything is the primary safe, but one lymph node is positive, whether to give adjuvant radiation or not. There are no clear-cut data out there, but there is a very large SEER-based analysis of over 20,000 patients. They have shown that even with one lymph node involvement, there is benefit in giving adjuvant radiation. So our general feeling is to give adjuvant radiation even with the one single positive lymph node.
Thank you, Dr. Moni. So that was very clear. There's a question on super selective neck dissection. I think this question was asked before also, but I think that plays on the mind of everyone. What is a super selective neck dissection? Dr. Sanjeev, sir, that's a question that's asked. Can you hear me, Dr. Sanjeev?
Yeah, I can hear you, yeah. So Suren, you want to address that question? Super selective neck dissection.
Yes, so super selective neck dissection was in fashion for some time, probably 10 or so years ago, but it's not something we practice anymore. And it is really for limited disease with limited suspicion of nodal disease. But our feeling is that, when you have made a decision to do a neck dissection, then you want to do an operation that is suitable for the volume of disease in the neck with the least morbidity. And so our standard practice now is selective neck dissection for small disease, modified neck dissection for larger volume disease, and if there is disease in the neck. So we have moved away from super selective neck dissection. We don't believe it reduces morbidity significantly.
Yeah. Sanjeev, sir, there's a question on, is there any role for contrast enhanced images? Is there any role for contrast enhanced images?
Abhinand,
Sanjeev,
would you be able to?
You want to direct it to somebody?
Yeah,
Abhinand, if you can tell us about.
Yeah, ma'am. Actually, in what sense, ma'am? In as far as the neck is concerned,
I think
sorry.
They haven't mentioned that, okay. But I guess you could just say for neck.
Yeah,
for neck.
Generally, whenever we do CT, it is always better to go with contrast enhanced CT scan rather than a plain CT scan. That would give us a little more extra information and more clarity on the status of the nodes. So that would be the recommended practice.
So Abhinand, I have two questions here. One is, in a patient with a tongue lesion and requiring a neck imaging, would you do a CEC contrast enhanced CT or MRI, or would you prefer an MRI?
Yes, sir. If it is an isolated lesion of the tongue and not showing any bony involvement in the cortical erosions, then MRI would be a preferable option.
And also, additionally, do you address the thorax as well in your imaging?
No, sir.
No. What about Moni? Any opinion on that?
I work in a very resource constrained setting. So what we do is we normally go for a CT scan with contrast in all the cases, except base of the tongue, we go for MRI scan. Now, when we do that, we have a protocol of doing both the CT chest as well as the neck at the same time in one setting, so the cost is lower, and we can avoid unnecessary surprises. Sometimes we can synchronous second primary and all that will be there. So we always do imaging of the chest along with the primary.
Dr. Suren, in your setup, do you do a PET scan for all these patients, or you stick to one of the to an MRI or a CECT?
Yeah, no, we follow exactly what Moni said. So CT, neck with contrast, primary and neck, primary neck and chest, and we do PET scans routinely for oropharynx. So tongue base and palatine tonsil, soft palate would get CT PET scans. And of course, we also have a group of patients who are cutaneous head neck malignancies. So melanoma would get a CT PET scan. And we also get a group of patients with nasopharynx. They would get CT PET scans. But oral tongue, buccal mucosa, sinonasal would not get necessarily, maxillary rather than sinonasal will not get a PET scan.
Yeah, so shall we move on to the next case? We have a 32-year-old male with a proliferative lesion in the posterior region of the buccal mucosa. As you can see, it looks like a verrucous lesion. And I would ask Abhinand, how would he go about investigating this lesion?
In this particular case, we have done CECT, contrast enhanced CT scan, to know the status of the neck nodes and to know the status of the involvement of the skin. And though it looks small clinically, we wanted to establish the extent of the lesion. So CECT was the modality, sir, imaging modality.
Now, in a situation like this, when we do a biopsy and it comes back to you as a verrucous hyperplasia, without evidence of malignancy, but clinically it obviously looks like a verrucous carcinoma kind of situation. Moni, how would you address this situation?
Yeah. See, verrucous carcinoma, very difficult to make a preoperative diagnosis. It's a challenge, okay? But we should understand about 10 to 20% of them will have invasive element within the tumor. So our recommendation is to go for a wide excision, like a cancer. If adjacent to the mandible, do a marginal mandibulectomy. And if possible, we try to avoid the neck dissection if we can do perorally. But if need a cervical approach, at the same time we do neck dissection.
Can I ask a question, Sanjeev?
Yes, Suren. Yeah.
Moni and the other panelists, how would you reconstruct that defect that you've created?
So my choice is in this location, buccal pad of fat is readily available. So I use a buccal pad of fat if the defect is small. If the defect is large, we're talking about a 4 centimeter or so size, then radial forearm flap is the choice.
What about a submental flap?
Yeah, go ahead.
Yeah, submental flap is also, I guess, one of the other choices. Matan, Any difference in opinion regarding not addressing the neck in a verrucous carcinoma case, which was preoperatively pathologically diagnosed as a verrucous hyperplasia?
Sir, I would wait for the, I explained the patient and I would wait for the post-operative histopathological features. And if it is a invasive squamous cell carcinoma, then I go ahead and do a neck dissection in these kind of cases.
So can I ask a question, sir?
Yeah, sure.
Yes, sir. Sir was saying that the radial forearm free flap is one of the option, or you're saying submental. Sir, in these situations, anyway, we are going to open up the neck. So are we going to do the elective neck dissection in these situations, sir, when we do for that purpose?
Yeah, I think if we are choosing opting, I mean, submental, you really do not need to extensively open the neck for a submental
for radial
flap. But if you are doing a radial forearm, you would probably do what is like an opportune neck dissection in any case. You know, whatever lymph nodes that one encounters, you would remove them for sampling purposes. So yes, that would be the decision. Yes. Rita, again, any questions from the audience?
There are a lot of questions, Dr. Sanjeev. There are a lot of questions.
How do
two of them
I'm
now.
sorry, I cannot get the panel of questions. I'm unable to do that.
There is an option of Q&A there next to the chat window. There is a Q&A window. If you can click on that.
Okay, sure. I got it just now.
Yeah. So actually, Rahul Thakur has asked, would level 2B be addressed in flat superficial lesions? Dr. Sanjeev sir, if you want to address it to somebody.
So level 2B, this again, I think I will give it to Suren because he was talking about the complications. So I think the question is basically, would you be required to address level 2B with the risk of, causing morbidity to the accessory nerve supply if you're doing an N0 NecK?
Very good question, and we published on this Vin Paleri, who's now who's actually a Pondicherry boy who now leads head NecK in the United Kingdom, was our fellow about 10 years ago, and we published on this. And there is no benefit in dissecting level 2B in an N0 NecK. Now, having said that, I must admit that the problem we have in our population is, unlike in India, our customers are all fairly substantial gentlemen and women. And so there is quite a lot of tissue in that area. And our tendency is, if we have a fair incision and fair access to level 2B, then we will clear it. But the short answer is that if you have a patient with an N0 NecK and there is not much tissue in level 2B, then do not dissect. You don't need to dissect level 2B. And there are studies that show very clearly that the morbidity to the accessory nerve is increased if you do dissect level 2B.
Thank you, Suren. There was a question asking, after the post-surgery, if one node comes positive without lymphovascular invasion or perineural invasion, with safe margins of the primary tumor, no extracapsular spread, would you still advise adjuvant treatment? Muni?
I mentioned about that paper from the US SEER paper that showed that not just oral cavity, they looked at the entire head and neck and showed that even with one lymph node positivity, there is benefit in giving adjuvant radiation. Having said that, there's a low risk area, for example, buccal mucosa, with only one, say, prefacial lymph node present, small volume metastasis, then I will individualize. I will hold the radiation. But very selective. You have to be careful where the patient going to come for follow-up and so on. General take home is that we have to give radiation. Only in exceptional situation you can hold the radiation.
So I think the answer to that would be that if you are not sure of the patient's follow-up, which in many cases is our situation in India, I think doing a elective neck dissection would be prudent, in short. So to Abhinand, there is a question about whether ultrasound is useful in determining depth of the lesion in tongue lesions. Abhinand?
Sorry, I didn't get you, sir.
Ultrasound is useful in determining the extent of lesion in tongue lesions.
You mean the depth of invasion, sir?
Yeah, with an ultrasound, intraoral use of the ultrasound.
Yes, sir. To some extent, it would be helpful, but definitely it will not establish categorically.
There's another question saying tongue lesions which approach midline do they require bilateral neck dissection? And if they require bilateral neck dissection, what would be the levels cleared on the ipsilateral side and the bilateral side and the contralateral side? Matan?
Sir, if it is in the midline, naturally we have to do bilateral neck dissection, and both sides it should be up to level 4, sir.
Okay, thank you. So I think we'll move on to the next case. Now this here is a this here is a patient who is a 76-year-old accountant. I think this is one of Professor Krishnan's case. He's got a left neck mass, which was seen on a large left neck mass, which was seen on the CT angiogram, which was an incidental finding. Episodes of headache, neck ache, unconscious episodes for minutes. Complete recovery from his loss of consciousness was seen on all the occasions. He's a reformed smoker since 30 years. Previously used to have 10 per day for 20 years. Hypertensive with type 2 diabetes mellitus. And how do you investigate this patient? Abhinand, do you have any choice of investigating this patient, starting from the clinical examination point of view? Abhinand.
Yes, sir. Since it's a case of unknown primary, definitely the thorough clinical examination would definitely help to know the lesion if it is within the vicinity of the oral cavity. But the PET CT would be an ideal investigative modality, sir, as far as imaging is concerned, because it has got very high sensitivity in identifying the unknown primary, especially from the oropharyngeal area when it is present in that area. So that would be one. Second thing would be doing an HPV analysis to know if there is any unknown primary coming from the oropharyngeal area. These two would be the investigative modalities I would prefer in this kind of situations over CT or MRI.
Yeah. So unfortunately, Abhinand, would a PET CT be able to actually allow you to plan the extent of surgery in this patient? Would you want to, do a definitive planning of the of addressing the neck with any other imaging modality other than a PET CT?
So then that would be again apart from PET CT, the CECT would be another option, sir, which will give us the idea of the next extent of the neck involvement. So
a CECT was done and it shows the extent of lesion, large lesion in the level 2 mid-jugular chain. And Surin, would you tell us how exactly did you proceed with this patient?
Yeah, so this is a complicated circumstance. So this man came incidentally, and he had this very large lesion that you can see measuring, 6 centimeters even clinically. And it didn't appear surprisingly fixed to prevertebral fascia. So there was some mobility. So we felt that this was still something that we could consider a resection for. But the problem was to try and identify the primary. So as Abhinand suggested, we did the CT scan first to look at the likely primary sites. So nasopharynx, oropharynx, there was nothing obvious to see. And in the hypopharynx on the left-hand side, there seems to be no mass lesion, but the hypopharynx was closed. So we thought that that would require investigation by an examination under anesthesia. And as you've said already, the CT scan of the lesion showed that this was a large lesion with obvious extranodal extension and multiple level lymphadenopathy.
Suren, can I just interrupt you here? I just want to go back to Abhinand. So after having done your PET scan and having seen this, clinically seen the size lesion, would you think of any further investigation to confirm the diagnosis regarding the mass in the neck?
Sir, since it's a large one, we can also opt for an USG guided FNAC, if enabled.
You would do a USG. Okay. Sorry, Suren, to interrupt you. You can continue with that.
Yes. So as Abhinand suggested, we did do an ultrasound guided fine needle aspirate. And nowadays, if our radiologists will make a decision on call. So if they get a very cellular aspirate, and don't tell me how a radiologist can tell if the aspirate is cellular or not, but if it's cellular and they can do what's called a cell block, then you can get immunohistochemistry on it. But if they don't think it's cellular, so if it's bloody, then they will then automatically go for a core biopsy, which will give them a solid piece of tissue that you can do immunohistochemistry, looking for both EBV and P16. So that's what this gentleman underwent.
Moni, do you have a different take on the management of this patient?
No, I agree. The first thing is we need to localize where the primary has come from. DL scopy is important, but that can be office-based copy. And if the office scope, if you find suspect lesion, then you need to put the patient to sleep and do the investigation. Now, with a large tumor, large lymph node with unknown primary, there are three potential areas of primary. One is the tonsil or base of tongue or a pharynx. Second is the nasopharynx, and third is the hypopharynx. So these three areas needs to be looked at. Yeah, PET scan is the way to go. Yep.
Yeah. So Suren, will you explain how you actually finally managed this patient surgically?
Yeah, so in fact, we did the PET scan. So in our country, you can't do a PET scan without a positive diagnosis of malignancy. The government and the health sector will not pay for a PET scan unless you've got a positive diagnosis. So we did the ultrasound guided core biopsy that showed it was a squamous cell carcinoma. It was stained for P16 positive. So we looked, as Moni suggested, in the tongue base and the tonsils. Clinically, there was nothing to find. And at the PET scan, you can see both tonsils light up. And according to our radiologists, the SUV was equal. So both were equally FDG avid. But of course, the disappointment was, as you can see in the extreme right, that there was a lesion in the right hilum. So we knew now that we had a patient who had metastatic disease in the lung, a large nodal disease, and still an unknown primary, because clinically there was no evidence of a mucosal lesion. And so we discuss all our head and neck patients at a multidisciplinary head and neck clinic. So this is a clinic where radiologists, radiation oncologists, medical oncologists, ENT, oral maxillofacial, plastics, and we also have physicians and occasionally allied health people sit on these meetings. And this was a particularly long discussion. And the feeling was that because this was a chap who at the age of 76 was still working as an accountant, and he had a symptomatic mass, that we had to offer him some sort of palliation because this is not curable disease. And the feeling was that surgery was the best palliation. So we have access to robotics. And so this patient had a transoral robotic right tonsillectomy and a left oropharyngectomy. So this is resecting the tonsil with a margin. So we take the superior constrictor and go right up to the areolar tissue that sits on top of the styloglossus and resect it as a compartment with the tongue base. And the reason we do this is transorally is that it is a relatively low mobility exercise. He did have a left neck dissection. It was a radical neck dissection, removing the sternomastoid, but preserving all other structures, including the accessory nerve, hypoglossal nerve, vagus, phrenic, etc. And we were conscious about the possible carotid artery issues with him because he had these episodes of loss of consciousness. And so again, to stress the importance of dissecting carefully. And he was also given informed consent of the possibility of thromboembolic neurovascular events during surgery. But that's what he had, a radical neck dissection preserving the accessory nerve, transoral resection, and then you have the pathology, I think, on the next slide. The pathology confirmed that this was a large 6 centimeter mass, which was extranodal. There was 8 out of 28 positive lymph nodes. All of them had extranodal extension. That there was a primary in the left tonsil. It was P16 positive. It measured 12 millimeters, and the margins were clear. So this was a T1N3 B NecK. Even worse was the fact that there was intravascular tumor in the internal jugular vein at the skull base end as well as the inferior end. So the whole internal jugular vein had tumor in it. And so the question came as to what else we do for this man. And there was extensive discussion. And the plan was that this was a purely palliative exercise, that the extent of disease and the lung disease would mean that he probably will have disease progression within the next 12 months. But at least he went home after 4 days in hospital and is eating, drinking, swallowing, able to drive his car. And we've given him some quality of life, but a difficult patient to discuss.
So Suren, I can see that no adjuvant treatment was given for this patient. Now, was it based on the philosophy of the fact that this was purely indicated as a palliative treatment, or on the fact that it was a HPV P16 lesion?
So it was based on the fact that this was, despite the fact that it was a P16 positive tumor, that we didn't feel that his outcome was going to be good. And our feeling was that we should observe him. And if he should get a recurrence, then palliate his symptoms when he does get, if he does get recurrence.
Moni, what would be any difference in the way you would look at it?
Okay. So here we have a patient who is a P16 positive smoker. Okay. So smoker with a P16 positivity, usually the smoking drives the tumor. Okay. Even though it's P16 is positive. Okay. So, but it comes under the intermediate type of group. So the intent of treatment here is palliation. So in our group, we would have given a chemo radiotherapy to the primary and the neck. Okay. But just only the oropharynx, not to the tonsil and the neck. And maybe as a second, they cannot cover the neck as well as mediastinum in one group. So they will do the neck and the oropharynx in the first sitting, and then do some kind of radiation to the mediastinum on a palliative intent. Okay.
Okay.
No,
Thank you.
Yeah, Moni, if I can ask, do you think the morbidity of chemoradiation is less than the morbidity of a surgical palliation?
See, yeah, it's a
76-year-old patient, by the way.
I agree. See, over 50 years, over 70 years old, adding chemotherapy has got no significant benefit. That is what the teaching says. But instead of giving platinum-based chemotherapy, we can add cetuximab type of with radiation. So that is fairly well tolerated. And again, our goal is palliative intent. So the surgery alone, how long? Within few months, patient might develop a relapse of disease in the neck. So I want to get as durable response as possible. It's a difficult call.
Yeah. Thank you.
We don't do palliative surgery, is rarely practiced.
Thank you, Moni and Suren. So we will move on to our last case, and then we have some time for taking more questions. So here we have a 58-year-old with no comorbidities, underwent a total clausectomy at first, bilateral neck dissection, which was reconstructed with a ALT flap. This was a T4A N1M0 squamous cell carcinoma of the oral tongue, and treated with adjunctive post CT-RT. 20 months down the line, he develops a right level 2 node. And it must have been a fairly big node to have been clinically felt. So in terms of investigation, Abhinand, what would be, this is a post-RT, post-surgery patient with a node in the neck, a recurrent node. Abhinand, any views on your imaging?
Yes, sir. The regular CE-CT scan, sir. The routine CE-CT scan.
Okay, you would do a regular CE-CT scan. Now, yes, I think we have a regular CE-CT scan. Before I show you that, would you not think about doing a PET scan for a patient who's come back with a recurrent lymph node in the ipsilateral side?
Yes, yes, sir.
Any reason for not opting for that?
No, sir. We would definitely do that also. But for the as far as you were asking for the neck node, so
evaluation, you would do a CE-CT.
Yes, but PET CT also would be an addendum to it to rule out any.
So here's the CT scan, which shows the lesion in the level 2 region, and as you can see, the lesion is encasing. It's extending into the post-hyaloid region and encasing the internal carotid artery. In terms of management, how would you go about it? Suren, any suggestions?
Yeah, I think I'll remain in Australia and not visit India to see this patient. I think this is. I don't believe that this is resectable. As you can see, it's encasing the internal carotid artery, and the question now is, what is the best way of controlling disease? So he's not a curable candidate. And the question then is to ask the patient and their family what outcomes they are expecting. Because one is just give the patient best palliation, and that is best supportive care, both in terms of pain relief and advice on how to manage the potential complication, which in this case could be a carotid blowout, and prepare the family for this. The other options are to use palliative re-radiation. This is 20 months now, I think you said, since his first treatment. And I think that our radiotherapy colleagues would look at possibly re-radiation, again, on the basis of symptomatic control. And finally, the other thing is to use what came out of India, which is metronomic therapy. So that's celecoxib and methotrexate.
Mm-hmm. Thank you, Suren. Matan, any take on this?
No, sir. It's we have to go for a palliative management.
Now, assuming you wanted to actually address or definitively treat it with a curative intent, what would be
curative intent? We can take the patient to the neurologist and do a balloon occlusion test and see, keep the patient awake and do a balloon occlusion test and see whether the patient's other side arms, both the hand and leg, everything is working. And in that case, if
Hello, Madan. Madan, you're muted again.
Correct. Madan is not muted, but I think there is some problem with this.
Okay, Moni, can you? This is one of your patients, so will you be able to tell us what?
Can you hear me, sir?
Yeah, Madan. Yeah, you were breaking
Hello?
up. Yeah.
Hello?
Yeah, Madan, I can hear you.
Yes, sir.
Then you are audible. Please go ahead. Yeah.
In this case, if you want to really take the patient as in curative intent, then you have to take the patient to neurologist, interventional neurologist, and do a balloon occlusion test to see whether there is patency in the carotid. And during the balloon occlusion test, they block the carotid artery, internal carotid artery for nearly 7-8 minutes and see whether the opposite side, hand and leg, are working. In that case, if it is working, then you can plan the surgery, explaining the patient and the relatives about the morbidity and the mortality of that disease, and we can do a carotid resection and a radical neck dissection.
Coming back to Moni, would you be able to tell us how this patient was treated?
No, this patient was treated like Dr. Suren mentioned, on the palliative intent. Was given on a palliative chemotherapy and controlled the symptoms as long as possible. But curative option to consider, as Dr. Madan was saying, that the taking the carotid artery is any benefit or not. So this is the paper from the Mansour group from Chicago, published some years ago, about 44 patients. They looked at whether resection versus stripping the tumor off from the carotid, and in both settings gave adjuvant radiation. Showed no significant benefit. So it's most of these settings we offer palliative intent cases. Now we have the checkpoint inhibitors are there. So if the patient can afford, immunotherapy can be considered. Nivolumab or pembrolizumab can be considered. And if there's a good response, maybe consider salvage by surgery, followed by re-radiation, of course.
Thank you, Moni. So as we see, we seem to have comprehensively addressed most of the issues. There are quite a few questions still left. If I can quickly go through, there's one on if the drop in survival rate to 50% with positive nodes has been reported for over 25 years. So has there been an improvement to this figure today with the advances in diagnosis and detection and treatment? I think it has been addressed in the presentation as well as in the cases that were presented. The advent of sentinel node biopsy has definitely improved the detection of the presence of occult node. So in that situation, where we used to do elective neck dissections, sentinel node biopsy would be of certain help, of certain value. And the second question was, do you think the 50% survival figure should be restricted to positive NecK nodes with extracapsular spread? I quite did not understand. Moni, did you kind of figure out what that?
I think the author must be referring to a paper by someone called ALBI from Pittsburgh, published some 20 years or 25 years ago. Clearly showed that if there's a nodal metastasis, there's a 50% reduction, and if the extranodal metastasis, there is a further 50% reduction. So there is a significant lower outcome with extranodal extension. Now, since then, all the Cooper study came up, all the chemoradiotherapy. Whether this concurrent chemoradiotherapy improved the outcome, definitely has improved the outcome, but it's much poorer compared to a lymph node metastasis without extranodal extension. That's the reason why we are staging this as N3B. Even at 1 centimeter lymph node with extranodal extension is considered N3B.
There is another question: which node is usually selected for sentinel node biopsy? I think the term itself is explanatory as to which node has to be. It is the sentinel node or the first lit up node that is usually selected for the sentinel node biopsy and sampled. So any other questions that I have missed out, Dr. Reena? I can see a lot of questions for which answers have already been given.
Yeah, already been given. Yes, sir.
Yeah.
Yes.
So I think
soft palate rehabilitation.
I think rehabilitation. I suppose you have another session, isn't it? Yeah, reconstruction.
Yes. Otherwise, the questions, yes.
Yeah, there are a lot of questions on reconstruction, so I am really not going to get into that because you already have a session coming up on that. So we will not really go into that. And to conclude, although it is a critical adjunct to treatment planning and diagnosing nodal metastasis, imaging is not really sensitive enough, as we have realized. So elective node dissection is the option available to you, especially since if you closely read De Cruz's paper which came out of Tatas, then ultrasound guided FNAC is superior to imaging in detecting NecK dissection or NecK disease, no doubt. However, it is very technique specific. Ultrasound guided FNAC with observation gives as good a prognosis, but like I said, it's a very technique specific management, and hence may not be useful in all cases. There was a mathematical model prognostic study which was done by Long, which is, it's an old study, but it interestingly showed, it also answers some of the questions which was asked about the thickness of the depth of invasion. It was seen that up to 1 millimeter, it was seen up to as much as 3.9% incidence of lymph node metastasis. In 2 millimeters up to 17%, and 3 millimeters up to 25% of involvement of occult nodes. The next step in refinement of the choice to manage clinically N0 NecK would be with the elective NecK dissection or saving it for observation is to perform I suppose a randomized controlled trial comparing elective NecK dissection with close observation in oral squamous cell carcinoma with in an N0 patient based on sentinel node biopsy. So you can do a RCT, one arm which addresses the N0 NecK with sentinel node biopsy and the other arm with END. In conclusion, NecK dissection is therefore the standard therapy for metastatic NecK nodes. RNT has been replaced by, as you can see, modified radical NecK dissection for selected cases of NecK dissections. The improvement in understanding the biology of the cancer and surgical techniques have allowed selective NecK dissection. You select the level to be dissected which are predictably going to be involved in the spread of the tumor. Selective neck dissection replaces MRND, therefore, and in future, sentinel node biopsy may become the standard of care as a standard practice rather than elective neck dissection. Now, the unanswered questions, of course, would be in the case of unknown primary, how do you treat it? Coming back to Suren, if there is a totally unknown primary and only the neck has been addressed, how do you manage it?
So I think that the current literature suggests that if you have an unknown primary and low volume disease in the neck, then neck dissection alone and close observation and follow-up is good practice. And there is about a 3% risk of the primary site becoming evident every year, as it were. So there's a 3% cumulative risk of identifying the primary. So these patients need close follow-up for a minimum of 5 years. If you have high volume disease in the neck, then our general principle is if it's P16 positive, or we will do EBV DNA studies to make sure that we're not missing a nasopharynx primary, then they would get a generous dose to the neck, so 64 gray to the neck, and often that will encompass the oropharynx. But if it doesn't, then our IMRT chaps would encompass the oropharynx on that side. So that's tongue base and tonsil if it's P16 positive. If it's EBV positive, then they'll radiate the nasopharynx. But we don't give mantle radiation anymore. The morbidity is highly significant and the returns are not that good. So does that address the question?
Yep. Choice of neck dissection in midline lesions, I think both maxilla and the midline mandible has been addressed in the presentation, as well as the cases that were presented. Specifically about salivary gland malignancies, Moni, N0 necks in salivary gland malignancies, do you, what is your opinion about addressing the neck?
If we know that the lymph node tumor is malignant in the first place, then we address the neck. And if you do not know the prime tumor is malignant and came as a malignant tumor, then we give adjuvant radiation if it is a high grade or intermediate grade tumor. Yeah,
I think parotids, you probably are is the only gland you probably will not investigate primarily. You go ahead and do the primary surgery and then look for the post-surgical histology to determine whether to do. But in case it's a minor salivary gland tumor, say floor of the mouth or palate, would you address the N0 neck?
Yeah, we do address malignancy. Once we know it's a malignancy, we do
okay.
Except adenoid cystic carcinoma. Adenoid cystic, there is no role for we are talking about mucoepidermal carcinoma. Adenoid cystic, there is no need to address it.
And coming back to Suren, because you see a lot of skin cancers, role of N0 neck in 6 skin cancers.
So skin cancers, if it's lip and it's a T1 lip, they won't get neck dissection. But if it's larger than T1 lip, they would get an ipsilateral neck dissection. And for lesions, so most commonly what we see is SCC of the parotid, but it's not primary parotid SCC, it's parotid SCC, which is SCC in lymph nodes of the parotid from a cutaneous primary. So those patients would get a parotidectomy neck dissection. And there was a multi-institute study led by the late Chris O'Brien that showed that there was survival and local regional benefit from addressing the neck at the time of the parotidectomy. But for small skin lesions elsewhere, we wouldn't address the neck on a routine basis. For melanoma, they would get sentinel node biopsy, and based on that, they would proceed to a neck dissection.
I think with this, Dr. Reena, I'm sure that we have answered most of the questions that were put either directly or indirectly through the presentation, and I can see that
Yes,
the panelists are looking pretty exhausted, and
tired.
yeah,
Yes.
we have gone through 2.5 hours, so I think I
Yes,
will
sir.
call it a day. So thank you,
Yes.
Professor Krishnan,
Thank you.
Moni, Abhinand, and Matan. Thanks
you,
for
sir.
the excellent presentation and the participation in the panel. And once again, thanks to the AMSI Tamil Nadu Pondicherry chapter for your excellent involvement in this series of lectures. Thank you.
Thank you very much, Sanjeev.
Thank you. Thank you,
Nice
Dr.
to see you
Sachin.
all.
Thank you, sir. Thank you all. Thank you, Dr. Moni, Dr. Suren, Dr. Madan, Dr. Abhinand. Thank you so much. Thank you.
Thanks, Reena. Thanks, Dr. Jamison.
Thank you.
Thank you for the presentation and participation. Thank you on behalf of our Association of Oral Maxillary Surgeons of India, Tamil Nadu and Puducherry branch. We thank Sanjeev sir, Professor Suren Krishnan, Dr. Moni sir, Matan and Abhinand for your fantastic efforts, and we had a good participation of close to 500. And thank you, participants, and next week again, we'll see at 11 o'clock in the morning. And I have posted the feedback in the chat box, so kindly click on the feedback to receive your certificates. And thank you once again.
Thanks a lot. Thank you.
Thank you so much. Thank you. Thank you very much. Thank you.
நீ ஒரு 2 क्वेश्चन தள்ளி விட்டியா?
5-6 தள்ளி விட்டாங்க. 2 தான் கொண்டாங்க.
ஐயோ.
Thank you, Dr. Madan.